Hello, good morning. Welcome back to our discussion of hormones. So, last day we have seen about thyroid hormones. So, we have already discussed about the production or how the mechanism is, how these thyroid hormones is produced in our body, and what are the different regions where we need thyroid hormone, or we have seen the actions of thyroid hormone and also the use of thyroid hormone about the replacement of deficiency of thyroid. So today, thyroid inhibitors. So we will be discussing about thyroid inhibitors. That means the drugs which are inhibiting the actions of thyroid or thyroid hormones. Okay, sometimes these drugs are also known as antithyroid drugs. But when we talk about the mechanism and all, antithyroid drugs are the drugs which act directly on the thyroid gland. But commonly we can call the different types of drug or different groups of drug have different types of mechanism. Only few will be directly inhibiting the thyroid gland. So commonly we can call these group as, or generally we can classify this group as thyroid inhibitors. And the thyroid inhibitors are the drugs which will inhibit the thyroid gland, or the conversion of T4 into T3, or the actions which are modulated by the thyroid hormones. So basically when the thyroid hormone is very high in our body, we can divide or classify mainly into thyrotoxicosis and hyperthyroidism. So the hyperthyroidism means in the blood there is high amount of thyroid hormone, but they may not be highly secreted from the thyroid gland. But in thyrotoxicosis means the excessive amount of thyroid hormone in our body is directly released from our hyperactive thyroid gland. So one is the cause is mainly from the thyroid gland, but the other case there is high amount of thyroid hormone in our body, but it may not be directly released from the thyroid gland. So anyway, the condition is there is high amount of thyroid hormone in our body. So the drugs and thyroid inhibitors will be the drugs which will reduce the activity of that high amount of thyroid hormones. So thyroid inhibitors, these drugs used to lower the functional capacity of hyperactive thyroid glands. Drugs used to lower the functional capacity of hyperactive thyroid gland. Thyrotoxicosis is a condition due to excessive secretion of thyroid hormones. That I have already told that what is thyrotoxicosis and hyperthyroidism. So thyrotoxicosis is due to excessive secretion of the thyroid hormones itself from the gland itself. But hyperthyroidism, there may not be hypersecretive gland, but in our body there is high amount of thyroid hormones. And also we can use for the disease like Graves disease and toxic nodular goiter. Anyway, both of them is a condition which is affecting the thyroid gland, and they will produce excessive amount of hormones, thyroid hormones. So the drugs are mainly used in Graves disease and toxic nodular goiter. Now the thyroid inhibitors, we can see the classification. First group, it will inhibit the hormone synthesis. They are known as anti-thyroid drugs. You can see here the drugs which directly inhibit the hormone synthesis is known as anti-thyroid drugs. Propylthiouracil, methimazole and carbimazole. So the first group is the drugs which inhibit the hormone synthesis. So they will be directly acting on the thyroid gland. Next group is which inhibit the iodide trapping. So in the first step of thyroid hormone production, it is the trapping of iodide from our blood by the thyroid gland. So the drugs which inhibit that iodide trapping is known as ionic inhibitors. They are thiocyanate, salts of thiocyanate, perchlorate or nitrate. So these may be salts of some other compounds. Okay. The third group is the drugs which will inhibit the release of hormone. So in the mechanism or in the process of formation of thyroid hormones, I have described under 5 headings. So there is iodide trapping, there is oxidation is there, coupling is there, then release is there, and finally the peripheral conversion. So the third group of drugs are inhibiting the hormone release, iodine, iodides of sodium or potassium, or organic iodides. And the last group is the drugs which will destroy the thyroid tissue. Destroy means complete destruction of that tissue, mainly the radioactive iodine, iodine 131, iodine 125 and iodine 123. Okay, so this is the group of drugs which are used as thyroid inhibitors. There are 4 main groups of drugs used as thyroid inhibitors. Now we will go to each group and each drug. First group, antithyroid, that is thyroid inhibitors. Inhibitors. They are thioamides. They are also known as thioamides. It will inhibit the thyroid peroxidase enzyme. So in the previous class I have told that for oxidation and also for coupling reaction, the enzyme which is modulating the oxidation and coupling reaction is thyroid peroxidase. Here these thioamides, they will inhibit this thyroid peroxidase. So it will prevent the oxidation of iodide or iodothyrosyl residue, and also the iodination, they will inhibit the iodination of thyrosin in thyroglobulin, and also finally they will inhibit the coupling of iodothyrosin to T3 and T4. So they are mainly inhibiting the step 2 and step 3, and here the main enzyme is thyroid peroxidase. So they will be inhibiting the step 1 oxidation reaction, or the processes in oxidation reaction and also in coupling reaction, but they won't interfere with the iodine trapping. So in the first step there is no action for our thioamides. First group or the drug propylthiouracil is also known as PTU. They will inhibit peripheral conversion of T4 to T3. So this have got an additional action. PTU, the propylthiouracil, even they are though they are thyroid inhibitors which inhibit the production of oxidation and coupling. Additional to that, they have a property for inhibiting the peripheral conversion of T4 to T3. So the final step of hormone release. But the other drugs, methimazole or carbimazole, does not have this action. So they don't have this action, but propylthiouracil has got an additional action for inhibiting the peripheral conversion of T4 to T3. Now the pharmacokinetics of these drugs, they are orally absorbed, so they can be given as oral drugs. They are wide distribution, so they goes to all over the majority of our cells, but the concentration is mainly in the thyroid glands. Yeah, you can see here they are widely distributed but concentrated in thyroid. So they can go to all over the cells, but the high concentration will be in the thyroid gland. And as they have got wide distribution, they can enters to all secretions, and also it can even passes the placenta. So when the mother is taking these drugs for any hypersecretive state or any other hyperactive condition, it can go to the fetus also. So these will lead to hypothyroidism in that fetus, and the metabolism is the liver and excreted in the urine. And the intrathyroid T half is longer. So when compare the T half from outside the body, outside the gland, inside the gland is more for thioamides. And the adverse effects, as we expect, they will inhibit the production. So it can lead to hypothyroidism. And goiter, which is reversible condition. Goiter means enlarged gland. Goiter means the word goiter is directly told that it is the just enlargement of the thyroid gland. So the enlarged gland, it is goiter. When there is enlargement, when there is overproduction, or when there is or stimulation of the gland, there will be high production. Here the negative inhibition will be low, because when we are inhibiting the production, the T3 T4 level in the body will be reduced. So the body, our hypothalamus will detect that there is less amount of T3 T4, so they will secrete the TRH to pituitary gland. So pituitary gland will secrete TSH and which act on the thyroid gland. So thyroid gland will get more TSH and started to produce more amount of thyroid hormones. So it will become a hyperactive thyroid gland will enlarge. This is known as goiter. But this process is reversible. When we stop the drug, the all procedures will be reversed. And the other adverse effects are GI intolerance. So gastrointestinal intolerance will be there, skin rashes, joint pain, and also infrequently some loss or graying of hair, loss of taste, fever, and liver damage. These all are very rarely, but even rarely we can see agranulocytosis. So for the thioamides, propylthioacetal or abimazole or methimazole, they have a chance for produce a granulocytosis. Now the use of thioamides mainly in thyrotoxicosis as definitive therapy in Graves' disease or toxic nodular goiter. Graves' disease or toxic nodular goiter. So this is the first and foremost use of thioamides, mainly used in Graves' disease and toxic nodular goiter, and also in pre-op hyperthyroid. So when there is an hyperactive thyroid or when there is a goiter, the usual treatment is by giving surgery. So when before going to surgery, our thyroid amount or the thyroid hormones level should be maintained in the body. Only when the thyroid is euthyroid or the production and the amount of thyroid hormone is equal, only then we can do the surgery. For making a hyperactive thyroid, for making that hyperactive thyroid to a euthyroid, we have to give some antithyroid drugs before surgery. So that we use thioamides, and also for along with our iodine 131. So it is a radioactive iodine 131. When we give radioactive iodine 131, it takes some time for destructing. So to balance that time, we give these thioamides. The advantages: there is no surgical risk, scars, injury to the parathyroid or recurrent laryngeal nerve. So as long as we can keep our thyroid gland euthyroid, or as long as we can keep our amount of thyroid hormones in our body normal, there is no risk or there is no need for surgery. So if there is no surgery, there is no risk of surgeries also. So there is no scar, there is no injury to recurrent laryngeal nerve, so there is no injury to parathyroid, or even there is no injury to superior laryngeal nerve. Okay. And if it induces a hypothyroidism, so when we treat with the thioamides and it causes the hypothyroidism, it is reversible. When we stop this drug, it can reverse to the normal. And also it is safe in children and also in young age. So in children and young age, there is very risk for surgery. So it is very difficult for surgeries, or we can manage with drugs. And also in pregnancy and lactation also, even though they can release or they can secrete through a placenta or the milk, the amount which reaches to the fetus or to the baby will be less. So it is, you can use PTU or methimazole in pregnancy or lactation, but with a caution. We have to discuss with the mother that there is a chance for hypothyroidism in the child. Then we can give this drug in pregnancy also. And the disadvantages, that if the pathology or if the disease is in the thyroid gland, as long as we keep the thyroid euthyroid, we can manage it, but we have to take this drug lifelong. Okay. And uncooperative, unintelligent patients also, the giving of drug daily, it will be very difficult. So this is a disadvantage. And also drug toxicities, there are, as we have already described, some adverse effects. After that, the granulocytosis is the most severe one, but it is a rare condition. Even though it is a rare condition, there is a chance for granulocytosis. So this is a disadvantage for the thioamides. Now the next group, ionic inhibitors, which will inhibit the iodide trapping. So the first step of hormone synthesis, it is the iodide trapping. The drugs ionic inhibitors will inhibit that process. Thiocyanate, perchlorate, nitrate. So these all are the majority of them, they will be like salts. Okay, you can see here they are inhibiting the first step. It inhibit the iodide trapping. So it will inhibit the first step. And these drugs or these compounds are highly toxic. So these are not clinically used. So ionic inhibitors are not clinically used, only in experimental conditions to produce hypothyroidism in some animals like rabbit, or which we are doing in our lab and all. We use this ionic inhibitors. For in clinical use in human beings, we are not using ionic inhibitors. Okay. So there is no it is potent 10 times potent rashes, fever, aplastic anemia, granulocytosis. So this is very dangerous for using ionic inhibitors. So we are not using in clinically, but in laboratory situations for making hypothyroidism in animals, we are using ionic inhibitors. Next one is iodine or iodides. Okay, they are the fastest acting thyroid inhibitors. So they are the drugs which will inhibit the release Okay, or they will release, or they will inhibit the release of thyroid hormones. And in Graves' disease, when we use this iodides in Graves' disease, the gland will shrink, it will become firm and less vascular, and the thyroid status will be normalized. So in Graves' disease means the thyroid gland itself is producing, or the gland itself is hyperactive. So we have to reduce the hyperactivity of the gland. In these conditions, when we use these iodides, the glands will be shrinking, they become firm, less vascular, and thyroid status will be normalized. So for if you are planning a surgery, then we can easily remove that gland when the gland is very small and when it's firm, less vascular, and also the thyroid status is normalized. Okay. And also the iodine or iodides, they can inhibit all facets of thyroid function. That means they can inhibit the iodide trapping, they can inhibit the oxidation, they can inhibit the coupling, they can inhibit the storage, they can inhibit the release. Till that phase, all phase can be inhibited by our iodine or iodides. They are mainly used in pre-op preparation. So for thyroidectomy in Graves' disease, iodine is given 10 days prior to surgery. So iodine is given 10 days prior to the surgery. The use, the mechanism I have already discussed, because they will make the gland more firm, less vascular, and they will the gland size will be reduced, and also they can help to maintain the or normalizes the thyroid function. So for doing a thyroidectomy, any thyroidectomy, subtotal, total, radical, any thyroid surgery, we can make euthyroid situation and make surgery very easy. And next is in thyroid storm. Thyroid storm is a special situation when we do, or when we do a surgery or some procedures on the hyperactive thyroid. It can release when we hold this thyroid, or when we make some activity on thyroid gland, hyperactive thyroid gland, it can release a huge amount of thyroid hormone into the blood. So it can cause different activities or different adverse effects or different adverse situation in our condition. So even it can lead to death of the patient on table. So at that situation, or not even the surgery, when the patient is in hyperactive thyroid state, even some infections or even some trauma can lead to this thyroid storm. The thyroid activity can increase, and it will release an enormous amount of thyroid hormone into our body, which leads to can lead to coma and death. So at that condition, or in that conditions, we can use this iodine, because I have already told that they can inhibit all the facets of thyroid hormone synthesis. Okay, all the 5 steps or the 4 steps can be inhibited. So in this emergency situation, we can use our iodine. Mainly used iodine is Lugol's iodine and hypenoic acid. So these 2 iodines are mainly used in thyroid storm. And prophylaxis of endemic goiter, iodized salt. So in the initial days, or even in the time of our early 1960s and all, there were a large amount of cases of goiter or enlarged thyroid glands in our society, and even in the places having higher altitude. So in the hilly areas and all, people, they will be having goiter. So our government has identified that this is due to the less use of iodine. So they have compulsorily made iodized salt. So now we can see that in our market, all salt, available salts are packeted salts are iodinized. That's due to this condition, endemic goiter. So it can be reduced by giving iodized salt. And iodine has also got an antiseptic action. Iodine has got an antiseptic action. So this is an action or use other than the use in thyroid. Antiseptic action, tincture iodine or povidone iodine. You will be familiar with the povidone iodine ointment when we use when there is any injury or any trauma or minor injuries, and all, we will apply the povidone iodine paste or creams. And also tincture iodine is also a different type of iodine preparation. Now the adverse effects of these iodines. Acute reaction. If the patient or if the human being is sensitive to iodine, it can lead to acute reactions. But in chronic use, chronic overdose, it can lead to iodism. So these are some conditions will lead to high amount of iodine in the body is iodism. And in adults, in adolescent age, when when you are using this iodine more, it can lead to flaring of acne. So flaring of acne in adolescent age group. And sometimes thyrotoxicosis can be aggravated in MNG. MNG means multinodular goiter. In that some cases there is some chance for overproduction of thyroid hormones, and which leads to thyrotoxicosis. And when we are using in overactivity or over chronic use in pregnancy or lactation, it can lead to hyperthyroidism for the baby. And also when we are using for a long term at a high dose, again it can lead to hypothyroidism and goiter. Okay. And the last group, this is known as the radioactive iodine. Radioactive iodine. Mainly two important isotopes, iodine 123 and also iodine 131. Iodine 123 has got a day half of 13 hours, and it is a gamma emitter. So the mainly used as diagnostic purposes. So diagnosis of 24-hour iodine uptake, and also for thyroid imaging. So even the half life is about 13 days, 13 hours only, and also it is a gamma emitter. Gamma emitter. That's why mainly used for imaging. So diagnosis of 24-hour iodine uptake, and also for thyroid imaging we are using iodine 123. But iodine 131 is somewhat different. It has got a T half of 8 days, and along with gamma it can emit beta. So it is a gamma and beta emitter. As we know, out of alpha, beta, gamma, delta, and beta is most destructive rays. So they therapeutically used for thyroid destruction in enlarged thyroid, and also in cancer thyroid, and in metastasis cases. So as it is a beta emitter, it can be used for destructing the thyroid gland in any situations, like any enlarged thyroid, or in cancer, or in metastasis. Metastasis means when the thyroid cancer is metastasized to any other parts. Here also we can use our iodine. So the iodine 131 can act on that metastasized area also. And when we think that it is an radioactive thing or radioactive substance, we might be thinking that it is given as some radiations, or when we are imaging and all, we are giving as a radiation, but it's different. It is administered as sodium salt. So the treatment we are administering is as a sodium salt of 131 dissolved in water and taken orally. So the drug is given orally as a solution made with the water and taken. Sodium salt solution of 131 iodine is taken orally. And for a diagnostic, when it is 123 for diagnostic purposes, it will emit 25 to 100 curie, microcurie. So the radiation will be assessed, or the radioactivity can be assessed as curies. Okay, for diagnostic purposes, it will be emitting 25 to 100 curie, microcurie. For the therapeutic purpose, it's more higher. It is 3 to 6 millicurie. So micro is smaller than milli. So 3 to 6 millicurie, and mainly used in Graves and toxic nodular goiter. For the Graves and toxic nodular goiter, the therapeutic level needed is 3 to 6 millicurie. Advantages: it is simple. As I told, it is not given by some radiation or some any technique. It is given as oral solutions of sodium salt of iodine 131, and it can be given in OP basis also, and also inexpensive. Okay, for other radiations of cancer chemotherapy, for radiations and all, it is very costly, but here it is very, when compared to that, it is very inexpensive, and there is no risk for surgery. So there is no risk for surgery, scar, injury to parathyroid, or our lateral or superior laryngeal nerves. And as it is destroying the cells, the treatment is a permanent cure, and once the hyperthyroidism is controlled, it is controlled forever. So they will be permanently destroying that cells, so there is no chance for hyperthyroidism. And also it can even destroy the metastasized thyroid glands or some other areas, some in some cancer and all, some other cells, even the pancreatic cells can also secrete the thyroid hormone. So when we are using this iodine 131, radioactive iodine 131, it can inhibit or it can destroy that cells also. So when the hyperthyroidism is controlled, once the hyperthyroidism is controlled with our iodine 131, it is a permanent cure. And it is the treatment of choice after 25 years. So in an adult which is less than 25 years, there is a risk for radioactivity and all. So it is a choice of drug after 25 years. And even when a lady is completed her family, we will advise, or the physicians now are advising, for radioactive iodines. Okay. Disadvantages, as I've told, they are permanently destroying the cells. There is a chance for hyperthyroidism. And also it takes some time for the response. So long latent period of response. It takes some time. So that's why I've told, when we are talking about thioamide use, we are using thioamides along with our iodine 131, because iodine 131 takes some time for action. So to make a balance, till that time we use thioamides. It also mainly contraindicated in pregnancy. So even it is a radio emitter, there is chance for radioactivity in the fetus also. So it is not advised to give in a pregnant woman, and also not in young patients. So even though it is a small amount of radioactivity only, there is only a small amount of radioactivity, it can leads to some other radioactivities in the body. That's why in young adults and also in pregnant women, it is not advocated to use. Okay. And the definitive therapy for hyperthyroidism is the thyroidectomy. So few words about thyroidectomy. And when the gland is very large or multinodular goiter, so when the gland is large, means sometimes there will be single node, sometimes there will be multinodular goiter. So the multinodular goiter, the treatment of choice is thyroidectomy. And also when the single large gland, one nodule itself is very large, the treatment of choice is thyroidectomy, near total thyroidectomy. Near total means only a few amount of gland will be left over, rest of the gland will be removed. For that we need pre-operatively antithyroid drugs given till euthyroid. So usually for 6 weeks and all, we will give these drugs to make the gland euthyroid and make the body to a condition that to a normal condition with a normal amount of hormone synthesis. And for thyroidectomy, potassium iodide solutions 10 to 14 days prior to surgery. We usually give iodide solution, potassium iodide solution from 10 to 14 days before the surgery to make the thyroid more firm, less vascular, and to reduce the size and all. And also after surgery, following the surgery, 80 to 90% required thyroid supplementation, because we are removing the thyroid gland itself. Only a few amount of thyroid gland will be left over near the region of our thyroid gland. So we have to spare the parathyroid gland. So some amount of thyroid gland may be left over with that parathyroid gland. So they will be keeping only a few amount of thyroid hormones. So to make 100%, we have to supplement with the thyroid hormones. Now thyroid storm. Thyroid storm I have already mentioned. It is an emergency vigorous treatment. This is an emergency situation and we need a vigorous treatment. And this is due to decompensated hyperthyroidism. When a patient patient when undergoes some stressful situation, mainly in surgeries or in any infection, any trauma or some other infections, can lead to this thyroid storm. It is an emergency situation where the thyroid gland will secrete a huge amount or enormous amount of thyroid hormone into the body. At that time, we have to use non-selective beta blockers. For the treatment of thyroid storm, the drugs used are non-selective beta blockers, propranolol 1 to 2 milligrams low IV, followed by 40 to 80 milligram orally 6th hourly, for symptomatic relief and most valuable measure. So the secretion of these thyroid hormone into our blood will causes more hyperactive situations, anxiety, tremors, heartbeat will be increased, tachycardia, shivering, fever, and also to control that clinical scenario or clinical situation, mainly we use our non-specific beta blocker non-selective beta blocker propranolol 1 to 2 milligrams low IV, then change over to oral treatment. Along with that, we can use PTU, propylthiouracil, 200 to 300 milligram orally 6 hourly, hypanoic acid 0.5 to 1 gram OD orally or hypoate. So these all are salts which are used to treat this thyroid storm. Along with that, corticosteroid, our emergency hormone, hydrocortisone, short acting corticosteroid hydrocortisone 100 milligram IV 8 hourly, followed by oral prednisolone to tide over the crisis or to cover the adrenal insufficiency or inhibit the T4 to T3. So these corticosteroids are as an additional action for inhibiting T4 to T3. So in this condition, in this emergency situation, to tide over this crisis, we can use corticosteroids, or we usually use corticosteroids. And diltiazem to control the tachycardia. As I told, there is an emergency situation, hyperactive situation where the heart will be beating very high, and which leads to tachycardia. To control this tachycardia, we have to give some anti-arrhythmic drugs. Out of our anti-arrhythmic drugs, diltiazem is a drug, 60 to 120 milligram or BD orally for tachycardia, and used when these patients are not controlled with our propranolol. Propranolol itself can control the tachycardia, but when the situation is more which cannot be controlled by our propranolol, we have to use diltiazem, and when there is any contraindication also, we can't use propranolol, so we have to change over to diltiazem. And the other measures should be maintained are rehydration, anxiolytics, external cooling, and antibiotics. So these all are have to be given along with these drugs. Then only we can serve that hyperthyroid situation, the thyroid storm. Now, beta adrenergic blockers. This group I have not mentioned in the classification because they have no direct role on the thyroid gland or thyroid synthesis. So the main drugs used are propranolol, non-selective beta blocker, and also other non-selective beta blockers are also used. But propranolol is mainly used in hyperthyroidism or thyrotoxicosis state. They rapidly alleviate the manifestations of thyrotoxicosis due to the sympathetic overactivity. So as I told, when there is a high amount of thyroid hormones, it can lead to overactivity of our sympathetic activity like palpitation, tremor, sweating, nervousness, myopathy, tachycardia. So these all features will be there when the patient is having hyperthyroidism or thyrotoxicosis. So these beta blockers will help to relieve that sympathetic mediated overactivity. When we block this sympathetic activity, there is no palpitation, tremor, sweating on this. So the symptoms of hyperthyroidism or thyrotoxicosis can be managed with beta blockers, but they have only a little effect on thyroid function or hypermetabolic state. That's why I have not mentioned this drug in classification. They have no direct action on the thyroid gland or thyroid hormone, but they can manage the symptoms of hyperthyroidism by inhibiting the sympathetic activity. And some miscellaneous drugs in high dose of prolonged period causes hyperthyroidism, goiter as side effect. So some drugs which can causes hypothyroidism, miscellaneous drugs, some the prolonged or high doses of some drugs can cause hypothyroidism. They are lithium. Lithium can inhibit the hormone release. So lithium has some action on hormone release. Amiodarone is an antiarrhythmic drug. Here it can activity of inhibiting the peripheral conversion of T4 to T3. So it can also causes hypothyroidism. And some sulfanoamides, para-aminosalicylic acid, they all inhibit the iodination and coupling. Sulfanoamides, the thyroid drugs are known as thioamides. Here sulfanoamides. So they have some similar structures or functions. That's why they can inhibit the iodination or coupling reaction, and they can cause hypothyroidism. And some drugs like phenobarbital, phenytoin, carbamazine, rifampicin. These all are induces the degradation of T4 to T3. So these antipsychotic drugs like anti-epileptic drugs like phenobarbital, phenytoin, carbamazine, and rifampicin are drug used in treatment of tuberculosis. They induces degradation of T4 to T3. Here this also causes hypothyroidism. And some recent advances in treatment is rituximab, some monoclonal antibody against CD20. We can use in sustained remission in patients with low TSHR antibody and to ameliorate the eye signs. So these all are some recent advances. So you may not be you don't need to bother about this, but these are also in advanced. And small molecule TSH receptor ligand binds to the transmembrane pockets of TSH receptors and inhibit the conformational changes necessary to its activation. So these all are recent advances. So you may not be, or you no need to worry about this, but you have to study all other drugs or activity. That's all. We have finished thyroid hormones and thyroid inhibitors. So along with this presentation, you have to read your textbook. Reading textbook is a mandatory, because we may not mention some points in our presentations, or we may miss to describe some points which we have not displayed in the screen. So you have to read the textbook along with the presentations. And the thyroid hormone and thyroid inhibitors are very essential or very important for your exams. Usually one question will be there for your exam from thyroid hormones. So you should read the thyroid hormones in your textbook and also the presentation. I hope these presentations are helping you, and we have noticed that many of the students are not watching the presentations, because the YouTube we can get the list those who have watched, or we can get the email addresses of those who have already viewed the presentations. And we noticed that many of you are not taking initiative to read this or to watch this presentation. Anyway, we will be giving you assignment, so try to finish that assignment. Whether you are viewing the presentation or not, we are not bothered. You should read the topic and understand something. So if you are not watching the videos or watching the YouTube link, then we will go to our previous method itself, so it will be easy for us also. And try to read the textbook. So reading textbook is a mandatory. Whether you watch the video or whether you see the presentations and all, you read the textbook and try to attend the assignments, okay, on time. So try to do that. Anyway, stay home, stay safe. Okay, thank you, bye.